Good morning. Good morning. I'd like to welcome everyone here for meeting number 2 of the Budget Review Subcommittee for Health and Family Services. As a reminder, no remote attendance by members is permitted for the 2024 session. All members must attend in person and be recorded as present. The meeting materials were put online earlier this week and made available for downloading for us. At this time, I will ask the secretary to please call the roll.
Senator Berg, Senator Titchener, Representative Fleming, Representative Raymer, here. Representative Stalker,
present.
Representative Wilner,
here.
Senator Mays Bledsoe, Senator McDaniel, Representative Bowling, Representative Bray, Representative Petrie, Representative Hevern,
Present.
Representative Moser, Co-Chair Bentley, Chair Douglas.
Present. Well, as you see, many of our members are not here, and I will have a conversation with many of them. This is a really important committee, and if they're going to be a part of this committee, I expect them to be here. They may not like that, but they'll get over it. You all are showing up. We have people in the auditory and visual media who are showing up, and I expect my colleagues in the General Assembly to show up. So I apologize to you out there in the audience right now. We cannot even approve our minutes from the last meeting, so we will do that at the next meeting. I do miss my colleague, co-chair, Representative Danny Bentley. This is the second meeting he's not been able to make, and he's got some things going on, so I want to extend some prayers for him. But there has been some change in the schedule. Mr. Birdwhistle with the University of Kentucky had called me and asked if they could go first. There are some scheduling issues, and I do think respectfully we need to grant that. So, Mr. Birdwhistle, if you would, present yourself up at the table, turn on your mic, and anyone else that you brought. Okay, yeah, they'll introduce them. And before you get started, I want to congratulate you on your new position at the University of Kentucky. Many people here do not know that you have served the University of Kentucky for a long time, and therefore the Commonwealth of Kentucky for a long time, and even the state legislature for a period of time. And your loss of retirement is actually the gain for the Commonwealth at this particular time. So if the both of you would please introduce yourselves, and then I'll have you raise your right hand.
So, thank you, Mr. Chairman. My name is Mark Birdwhistle. I am the Senior Vice President for Health and Public Policy at the University of Kentucky.
Yes, and thank you, Chair Douglas. My name is Angela Derringer, and I'm the Executive Vice Dean for the University of Kentucky College of Medicine.
Thank you very much. Will you both raise your right hand? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Yes.
Thank you very much. You may begin.
Well, again, thank you for allowing some flexibility in the scheduling. I'm here today, and you can see my new title. After 30 years, I moved out of my UK hospital office and took on this new responsibility. And part of that responsibility is to centralize the government relations activities across the campus, but most importantly, to build a better partnership with the Kentucky General Assembly. We know we've got issues that we need to address, and I felt like I was uniquely positioned to do that. So we're assembling a team, and you have my commitment that you can reach out to me. We will hear your concerns, and I want to build a partnership. I think that is the expectation for all of us, because we want to get to the same place. We may be driving different cars, but we want to get there together. So thank you for that. So what I'd like to do very quickly is give you a journey of where we've been for the last couple of years. We've done a revision to our strategy. And this started in January 2023 when we had new leadership. And the feeling was we needed to connect better with our clinical partners that had been with us for a number of years. So we did a series of focus groups with community leaders, leaders in the health system, physicians, providers, and hospital systems. And we listened. And the results of these three blocks are the results of what we heard. We canvassed 13 different entities and said, what is UK healthcare doing wrong? And we learned a lot. It wasn't the most comfortable thing to listen to, but we set apart a journey of addressing those concerns. So, in a very simple explanation, we heard loud and clear, we want UK healthcare to focus on taking care of the sickest of the sick. We don't want UK out taking care of primary care and secondary care. When we need you, we want you to be there. And you can see on the slide, we had planned a community hospital in Hamburg. That was perceived as us stepping outside of our swim lane. We don't do community care. We don't do primary care. We do what we call advanced subspecialty care. So that was very eye-opening, and I put the big red X there intentionally to communicate that we heard. So the second piece that we see is taking care of our people. That is our employees. Many of the university employees cannot get access to health care, and they're having to get care outside the system. So we will be opening up a series of clinics around the campus and in contiguous counties expressly targeted to our employees who work in those communities, because we feel that is our obligation. So the second piece, the third tier, is our workforce challenges. And Dr. Derringer will go into that in just a minute, because we see that as our obligation. We know the nurse shortage, the physician shortage. We need to be a partner with our networks and helping them recruit. I mean, we grow the workforce, so we need to start getting that connection going. So the message we received loud and clear from our clinical affiliates was, when our folks get that sick, we want them to come to UK. We want them on campus. We don't want them at a community hospital off of I-75 and 64. We want them on campus. So I'm going to drill into these very quickly. Advanced subspecialty care. We're going back to a strategy that has worked for us very well for the last 15 or so years. Our vision and our goal was, if a Kentuckian wakes up in the morning and has some catastrophic illness, they should not have to worry. Can they get to MD Anderson? Can they get to Mayo Clinic? Can they get to Vandy? That care should be provided at the University of Kentucky. And that is our mission, and that's where we are going to focus extensively on. So the second point there is, we used to be the top hospital in the nation for receiving transfers from other hospital systems. We're still in the top 10, but that is who we are. And you're going to see in the next slide the reason for that. But I will focus at the bottom, transplants. You can see there we have done so far in this fiscal year, actually we ended 24, yeah, we did, 229 transplants. That's solid organ, heart, lung, liver, kidney transplants. That puts us on the cusp of being in the top 25 percentile of all transplant centers in the United States. So that is advanced subspecialty care. And before we leave this one, I want you to look at the graph to the side. This is who we see as our collaborator, who we compare ourselves to. Who do we benchmark ourselves? We benchmark ourselves to Cleveland Clinic, Ohio State, UPMC at Pittsburgh, Vandy. That's who we are, and that's how we compare ourselves. And you can see here, I will get a little bit geeky on you. What hospitals do, health systems that are academics, measure themselves according to the care needs of the patients that they take care of. And you can see there, UK healthcare, our case mix index, which is just a mathematical formula of how sick our patients are, is 2.48. There are only 2 in this list of top academic health centers that take care of patients that are sicker than our patients. Cleveland Clinic and Duke. It's really hard for me to say that word Duke, but occasionally I have to. So I think that gets the perception of who we are and what we are and why we are. So when I met with the chair a few weeks ago, he said, Mark, I've got a question. We want to know where UK is heading. We're hearing this thing about Good Sam. We're hearing this thing about acquiring health systems. I'm somewhat embarrassed to say in the last 2 years, we had to turn away 10,000 transfers. Now, year before last, it was 6,000. Current year, it was 4,000, so we're better. But regardless of what that number is, we have to have capacity on the Chandler campus to be able to accept those transfers. That is the expectation. That is our obligation. And I would thank the members of the General Assembly for, in the budget bill, you supported an authorization for bonding for the expansion. And you can see there is a schematic. I hesitated whether to show it or not because in reality it probably won't look a thing like that. But we have to build out a better capacity on Chandler. Drilling into that, we've got challenges. When UK purchased Good Samaritan Hospital, it was intended that when the new Pav A tower would be built, that we could sunset sunset Good Sam. And that has not worked out. So we're still having to put Good Samaritan Hospital together with duct tape, rubber bands, and baling wire on a day-to-day basis because it's a 1950s chassis. Now, I'm sitting here in a 1950s chassis as well, but I guess buildings don't last quite as long as people do. In addition, we've got a lot of the original part of the original Chandler Hospital, Pav H. So that has to be dealt with because that's 60 plus years old. So those are our challenges. We intend to have Good Sam down and a new on-campus facility built. Our target date is 2029. The other piece to this, we broke ground in April on a new Markey Cancer Center building. We last year announced that we have received the highest distinction in cancer care. So we have the comprehensive designation. And right now, people getting cancer care have to go in that last box that shows you all of those little arrows where people have to go for cancer care. And these folks are sick. So we need to put them in one place to make it easy, convenient, because sometimes they have to go to multiple buildings. So that is another piece of construction. If you drive by, you can see the construction happening. So moving quickly to the next one, taking care of our people. When we originally did this slide, or did our refresh, we just had the words taking care of our people. We did a modification that was approved by UK's Board of Trustees in April. We heard loud and clear in the 2024 session that we had taken our eyes off of our partners. And we had sent conflicting messages. So we have added that, the board has approved, and will hold us accountable for meeting the needs of our partners. So how are we doing that? We have a lot, I know during the session there were a lot of maps out there of where UK is. I wanted to give you just a subset of what we're doing and where we're doing it. We're doing pediatric cardiology in Pikeville, ARH, and Lake Cumberland. This means hundreds of kids are getting care close to home so they don't have to come to campus. Sometimes that travel from home to Lexington is too difficult and unavailable to folks. You can read the rest. I won't go through each one. Ovarian screening, managing a NICU, neonatal intensive care units in Pikeville, Corbin, and in Frankfurt, gynecological oncology, ophthalmology, orthopedics. So we are serving the needs of the Commonwealth. Now, we are doing this at the request of the health systems in the community. I think there's a perception that UK, and I hated that word predatory, this is in response to the community needs. And these are things that we are doing in partnership with the community providers. We took our eye off of the ball for 5 years or so. This is a top priority for the university right now. So, the purchase of the King's Daughters Medical Center in Ashland created a lot of questions. It kind of steps on the messaging that I just went through. But the day that UK had its first COVID patient, March the 5th of 2020, we had a visit from the leadership at King's Daughters. Our Lady of Bellefonte Hospital closed with 469 jobs and 50-some medical providers. The COVID pandemic was approaching. They wanted UK to do something to help them secure health care in that region. We did it. We assimilated them through a management agreement, and then ultimately they became part of UK. Where we failed, and I've said this in a couple of committees, is when you put that UK brand in front of that name, that brings with it an expectation of service, not predator. And so we're readjusting a lot of the narrative to say, when you have UK in front of your name, you go to a partner and say, what can we do to help you be successful? It's not what do we do to crush you. And this is community health care. This is not our forte. So we've learned that lesson. We're strong. We got a couple of clinics that you probably have heard about that we're working through. How can we partner with existing providers there? Because to play to the strengths of UK, we can help grow the workforce for those providers and not have to do it ourselves. So, most recently, the St. Clair Partnership. We did get legislative approval in the 24 session to move forward with this transaction. In all candor, St. Clair probably would have been our first acquisition. When I started working at UK Hospital 30 years ago, I was told, Mark, be nice to St. Clair, their family. And I snapped that picture that's in kind of the maroon box there. These are all of the clinical partnerships that we have going on with UK physicians and providers in that space. So St. Clair realized they needed a partner. Standing alone as a smaller health system, that's not survivable. So they did an RFP, had a lot of responses, many of out of state, even out of state academics. Fortunately, they chose UK to be the partner to go forward. Dr. Derringer is going to talk about the Rural Physician Leadership Program there, but that is a phenomenal program. We house some medical students do on campus in Lexington year 1 and year 2, but their year 3 and 4 classes are taken at St. Clair. So there's a lot of UK interconnectivity already there. And quite honestly, we could not put that at risk.
And if you don't mind, Mark, I'll just talk a little bit about that program. We consider the Rural Physician Leadership Program one of our crown jewels of our medical school at UK. It started in 2008. Our first graduates came in 2012. Since 2012, we've had over 120 graduates. 60% of those graduates stay in Kentucky to practice medicine. That is our goal. And the vast majority of them practice in rural areas. As Mark mentioned, we have a priority to help with the physician workforce needs in our state. We know that Kentucky residents who go to medical school in Kentucky, who do their residency training in Kentucky, are more likely to stay in Kentucky and practice. And that is what we need. We want to expose students to rural medicine, to practicing in rural locations. And that is part of what this Rural Physician Leadership Program, or RPLP as we call it, is all about. These students also have an opportunity to get a certificate, a leadership certificate from Morehead State. We not only want them to practice in rural communities, but we want them to be leaders in rural communities. So this is, as Mark said, these students do their first 2 years, their classroom learning in Lexington, but they spend those clinical years at St. Clair and other practices around Morehead. It is one of just our favorite things to talk about, because it is probably, I think our dean would say that we produce more rural physicians through this program than any other program in our country.
So, moving to the next one, I'm floating this term, and I floated it with Senator Douglas first. So far, nobody's pushed back on me. UK serving as a backstop for our partners. And a good example of this happened a few weekends ago, where UK has a partnership with a particular NICU, managing the neonatal unit. because of vacations, they were going to have to close the NICU over the weekend. Some of our neonatologists at UK adjusted their schedule and spent the weekend in Pikeville, so the NICU could stay operational. That's what we do. That's where we excel, and that's where we need to get back to. So, you want to wrap up real quick?
Sure. Again, just talking about UK as an academic health system, I think that many of you know we started some regional campuses in addition to Moorhead around 2017, 2018. We have a medical school campus in Bowling Green, also in Northern Kentucky. We also started several residency programs in Bowling Green. Again, knowing that our students who train in our state will stay in our state. We have about 7 residency programs in Bowling Green, including internal medicine and obstetrics and gynecology. We are trying to grow the number of doctors in our state to stay in our state. So we have increased our enrollment. We are so thankful to the General Assembly for helping us with a new health education building. That is going to allow us to grow the number of students in Lexington. We were landlocked and could not do that. That was part of why we started the regional campuses. So over the coming years, we have, over the past few years, we've increased our class size from 136 to 201 students. And we are also starting some new residency programs. I got the opportunity to speak to some of you all a couple of weeks ago about that. We are starting an internal medicine residency program in Pikeville, as well as Ashland, and a family medicine residency program in Ashland. As Mark mentioned earlier, we understand that the UK is here to do advanced subspecialty care, but we need primary care doctors out in our state. So that's why we are working to improve and increase the number of students and residents who will become primary care doctors in the rural areas of our state. And that is absolutely a priority.
So I think our next slide is questions.
Well, first of all, I want to say thank you so very much, Mr. Birtwistle and Dr. Dieringer. I did reach out to this group because there were a lot of concerns, not just in the legislative space, but as I told you, in the medical space or healthcare space all across our Commonwealth. And I want to thank you both for bringing in the information that you brought in. It's going to be very helpful, not just for those people who are in the private sector, but also those practicing physicians who indeed were wanting to hear those words that you want to have a partnership, that we all work together, to let our public know that as I've said, I still remember when my youngest came to me and said, "Dad, I don't want to disappoint you, but I'm going to do academic medicine." She's on staff at University Hospital up in Philadelphia, University of Pennsylvania. She's an ear, nose, and throat surgeon. And I said, "Dear, I don't care whether you do academic medicine or private practice medicine. I want you to enjoy the practice of medicine and take care of your patients." And that's kind of what I'm hearing from you all today. I mean, it's really encouraging. I hope to also reach out to the University of Louisville. I don't want to slight them, but also have a conversation with them. But with that being said, I'm going to open it up for anyone who may have some questions. No. Okay, Senator Berg.
Good morning. Thank you very, very much for the presentation. And I want to say, to begin with, first of all, I really appreciate the understanding that our major university medical centers need to be tertiary centers. We need that in this state. There is no way for us to get that level of medical expertise out to every corner of the state. It's not possible. And again, I very much appreciate the orientation as far as training primary physicians where they need to be, because the vast majority historically of residents have stayed and practiced where they train. That is a trend across this country that has persisted for decades. I wish I could pull it up because I can't. Last night, I saw a survey that was actually performed by med students at the University of Louisville School of Medicine, where they reached out to medical students across the state. And I believe the number they came up with was 78% of those medical students are planning on leaving this state for their residencies because of the restrictions that are being placed on medical education here in Kentucky. Are you all seeing anything like that? Any decrease in the number of students applying? Any decrease in the number of residents that we're able to accept here in the state and keep in the state? Because I think those numbers are critical to the future of healthcare here in Kentucky.
Yeah, thank you for that question. I'll address that. To be honest, we have not seen a decrease. We had last year 4,000 applicants to our medical school, and we have 200 spots. Now, granted, only about 400 of those are Kentucky residents, but that is on trend. So we have not seen a decrease. I do hear anecdotally, occasionally, particularly in the field of obstetrics and gynecology, some students or residents want to train in other states. We have not actually seen that at UK. We are still inundated with applicants to do an OB residency at our university. So thankfully, we haven't seen that play out.
A follow-up, sir.
Yes.
Have you seen, are you all keeping track of your residents that finish the program and stay here in Kentucky? Is that percentage stable?
Yes, it is stable. It's actually growing.
Yeah.
Awesome.
It's better.
It's
Thank
growing
you, because that's what we
It's
need.
trending the right direction.
That is what
And that-
we need.
And that's why we appreciate the opportunity to tell this story.
Thank you.
Thank you, Senator Berg. Representative Wilner.
Thank you, Mr. Chairman. And my question was very much along similar lines as my colleagues, but I was really encouraging to me to see the number of students that you have increasing and the number of students you're graduating. I was just going to ask if and maybe it's too early to tell, if we're seeing a commensurate increase in the number of physicians in the state. And I'm asking that particularly, it's really one of the things that keeps me awake at night. We've had a number of presentations, not from you, but from others, about the number of physicians who have left the state. And I'm wondering if your increase is really going to lead to more providers in the state.
I don't have data on the number of physicians who are staying in the state, but I will say that our number of graduates who are staying in Kentucky has increased from about 24% a few years ago to 42%. So we are very encouraged by that.
Thank you.
Representative Stalker.
Thank you so much. Good morning, and thank you for being here. So, along the same lines of some of my colleagues here, I'm a little bit confused by the information that you all are giving, because you're saying you're not seeing a decrease with your medical students, correct? Applying to programs. But there was something, and I had to look it up because I thought I'm having a moment here, if not. So there was an article, Kentucky Health News, that said the Association of American Medical Schools say that 15% fewer U.S. medical student graduates applied to Kentucky residency programs in the 23-24 academic year, and part of that trend related to states' strong anti-abortion laws enacted after the federal right after Roe. And so I'm just wondering, so are you saying that it's affecting other schools and not necessarily specifically U of K, or there's some sort of confusion here, and I don't know if you know what I'm referencing, but happy to share it with you. But
Sure. I don't know exactly what you're referencing. I guess that I can put it in this aspect. Our residency programs are still getting hundreds and hundreds and hundreds of applicants, very good applicants. We don't have any problems filling our residency programs and fellowship programs with very high quality young physicians. We are prioritizing as much as we can Kentucky students, again, so that they will stay. So I'm sorry if I gave incorrect information. I don't know from a global standpoint, the AA, or from a country standpoint about a decrease in number of applicants, perhaps applicants from other states. I will say that we have not seen a decrease in applicants from our own state, and we have more applicants than we can certainly ever train.
thank you.
Thank you very much. Mr. Birdwhistle, I know that you have a schedule that you must keep, and I want to thank you. And again, Dr. Deeringer, I want to thank you all for the time that you've spent with us and for the information and the clarification that you've been able to bring to members on this committee.
Okay. Thank you all very much.
Yes, thank you.
We'll be back.
While they are stepping away, next we'll have Commissioner Eldridge and Ms. Craig with the Department of Aging and Independent Living come and give us an update on the Office of Dementia Services. While they're getting settled, we now have a quorum, and we can approve the minutes from June 5. Do I have a motion? Yes. Motion second. I have a motion and a second. All those in favor say aye. Aye. Oppose? Motions have been approved. Thank you. The minutes have been approved.
If we could have some technical assistance, the slides are not showing up on the computer here.
But I don't see Ms. Craig. That's not Ms. Craig. Is it? Well, very, very quick. Thank you so very much for coming in front of the committee this morning. If you would, just simply introduce yourselves to the committee.
Yes, my name is Victoria Elridge. I serve as Commissioner for the Department for Aging and Independent Living.
And my name is Jennifer Craig. I'm the Office of Dementia Services Coordinator.
Thank you so very much for being here, and welcome. If you would, raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
Yes.
Thank you so very much. You may begin anytime you wish.
To the committee, thank you for bringing us here today. We are always happy to talk about the Office of Dementia Services that was newly established just a few years ago. I'm going to turn the presentation over to Jennifer, and she will go through that, and we look forward to any questions or additional input at the end of the presentation.
So, good morning, and thank you for your time. It is my pleasure to address you today and reflect the journey and the significant milestones of the Office of Dementia Services. These statistics highlights the significant impact of dementia on both individuals and caregivers in Kentucky, as well as the growing need for supportive care services in the coming years. The growth of individuals with a dementia diagnosis has increased over 14% to 86,000 Kentuckians in 2025. Individuals living with dementia are seldom alone in their journey, and they often have caregivers and a care team to also support them. The cost and hours of these unpaid caregivers, these individuals who are providing care, are alarming and play a huge part in why the Office of Dementia Services focuses on establishing an informed, confident, and healthy care team. Another reason to support and nurture unpaid caregivers in Kentucky is the projected need for home health and personal care aides in the future. The Office of Dementia Services is focused on increasing awareness and support for individuals affected by dementia, whether paid or unpaid. We are also focused on creating a dementia-trained workforce that has the tools and training required to identify dementia and assist as the disease progresses. The timeline is a testament to the dedication and collaborative spirit that has driven the progress. In March of 2021, Senate Bill 74 established the Office of Dementia Services, and Senate Bill 61 mandated dementia training for direct care providers. By July, a 3-year, $1 million grant was secured, empowering the office to implement initiatives and reach more communities. And utilizing that funding source, I was hired as the first ODS coordinator in October. March of 2022 saw the launch of the Bridging the Gap, supported by the ACL grant. In June, a dementia education webinar series was initiated. And by July, mandatory dementia training for all area agency staff and the Older Americans Act nutrition program providers was enforced, enhancing the commitment to professional development and quality care. In June of 2023, advocacy efforts led to the passing of House Bill 125, mandating Alzheimer's risk reduction material and public health initiatives. And in August, a 5-year, $2.4 million CDC grant was awarded, expanding the office's reach and enhancing a collaboration with the Department for Public Health. All that brings us up to this year. In January, the office expanded with the hiring of a bold project manager, and the Bridging the Gap program evolved, creating dementia care specialists who provide tailored and guided assistance to 31 counties in Kentucky. And just this month, House Bill 6 allowed the increase of restricted funding and a new 5-year, $64,000 partnership with U of L Traeger that aims to further enhance dementia awareness within the workforce. Commissioner, do you have anything to add?
No, you're doing great. Thank you.
Thank you. As we envision the future of the Office of Dementia Services, our focus remains on expanding and enhancing our impact in the community. I will highlight just a few of the plans today. We will be developing and implementing a comprehensive dementia state plan in collaboration with the Alzheimer's and Related Disorders Advisory Council and Bold and Kentucky work groups. This plan will set a clear objectives and guidelines for improving dementia care across the state, focusing on dementia and caregivers, brain health, risk reduction, and health equity. The office will also be implementing initiatives identified by Bold work groups. These public health initiatives will focus on promoting brain health across the lifespan and reducing dementia risk factors and much more. We will strive to increase our ability to gather and analyze dementia data. By improving data collection methods, we better understand the needs of those affected by dementia and can tailor those services accordingly. And we will continue to focus on dementia and risk reduction education and workforce development, with the delivering of tailored training programs designed to empower caregivers, health professionals, and the community. And finally, we will focus on ensuring sustainable growth by continually searching for alternate funding sources to support and expand the programs and services that can be delivered in the Commonwealth. ODS has secured over $3 million in time-limited grant funding that supports the office, along with some programs and initiatives. The Alzheimer's Disease Program Initiative Grant is used to support the Bridging the Gap program and the dementia care specialists. The CDC Building Our Largest Dementia Infrastructure grant is used to support the Bold in Kentucky initiatives, and a newly paid partnership with U of L Traeger Institute will focus to increase workforce development and dementia training. In January of 2024, the office introduced dementia care specialists into Pennyroyal, Buffalo Trace, and the Bluegrass area agencies on aging. Utilizing the Alzheimer's Disease Program Initiative Grant through the end of 2025, These 5 dementia specialists serve 31 counties in Kentucky and are housed within their communities to provide comprehensive support and services to individuals with dementia and their families. They receive specialized dementia training to help them aid and assist with identifying and locating services needed for individuals to remain in their home for as long as safely possible. These specialists are also there to help navigate long-term care placement when or if that time comes. The dementia care specialists provide community education and support in the form of education sessions and by establishing memory cafes or support groups. They work with local physicians and other healthcare providers to assist with care coordination and remove any barriers that might affect care. These specialists also serve as a catalyst for creating and sustaining a dementia-friendly communities within our Commonwealth. I want to thank Legislatures Meredith and Mosier for your support in securing the Building Our Largest Dementia Infrastructure BOLD grant funded by the Centers for Disease Control. This is a collaboration between the Office of Dementia Services and the Department for Public Health and aims to enhance the public health infrastructure to effectively address dementia and brain health across the lifespan. This 5-year grant focuses not only on caregivers and individuals that have a dementia diagnosis, but also those with an increased risk for developing dementia later in life due to modifiable risk factors. BOLD focuses on risk reduction, early detection, brain health, health equity, and implementing strategies to reduce dementia risk, improve care, and support those living with the disease. During the first 2 years, we are establishing statewide dementia coalitions and 4 work groups focusing on partnerships and policies, data measurement and evaluation, workforce development, and community engagement and education. These work groups will be instrumental in developing our dementia state plan. In years 3 through 5, we will implement activities aligned with this state plan through these work groups and community partnerships. The work groups are championed by community partners across the state and from entities such as the University of Louisville, the University of Kentucky Sanders Brown, Norton's Neuroscience, the Alzheimer's Association, and local and state health departments. The office collaborates with numerous universities, health facilities, and community organizations to maximize its impact on individuals living with dementia and their caregivers. Additionally, the office staff frequently participate in community outreach events and present at both state and national conferences. Over 100,000 Kentuckians have benefited from the Office of Dementia Services education through various initiatives, whether it's the Dementia Webinar Series, the community education events, evidence-based trainings, or the efforts that encompass mandatory training for direct care providers, area agency staff, and nutrition service providers across through older Americans. In May of 2024, I was named the Norton Neuroscience Institute Person of the Year for my passion and dedication to the office in fostering partnerships and collaboration that is moving this office forward. In conclusion, the future of the Office of Dementia Services is promising. With ambitious goals and a clear vision, we are dedicated to building on the past successes, continuing to innovate, and expanding our efforts. Thank you for your continued support.
And I want to extend the thanks of myself in particular and this committee in general for the presentation from both you, Madam Director, and Madam Commissioner. One of the questions that I would like to sort of open up with, and I may have missed part of this. People are asked to take specific training to become a dementia care specialist. Is there a baseline training expectation prior to being able to take that training?
So with the dementia care specialist, that is a pilot project. So several other states have got dementia care specialists, dementia navigators, they're calling these other things. But right now there's not a baseline. We're utilizing the area agency on aging staff and really focusing on their staff and the family caregiver coordinators within those. So they have specific training that the family caregiver coordinators have to have. They're dealing with a lot of individuals with dementia. So this really did work hand in hand, and it enhanced what they could bring to the table. So there's not a baseline, because statewide there's not a baseline, or nationwide there's not a baseline. It is something we are working with, and I'm working with other states to figure out what is that good baseline.
And Senator, I will add to that, within the legislation that Jennifer had discussed regarding personal service agencies and additional licensure categories, those that are providing home health and so forth, Jennifer in her office does approve dementia curriculum prior to it being implemented to ensure that there is that oversight for those that are providing that medical-based care in the home to individuals with dementia.
Okay. Thank you so very much. We have some questions. Representative Wilner?
Thank you, Mr. Chairman. Thank you for the presentation. This is an issue that has personal relevance for my family as well as for, many families across Kentucky. So I'm grateful for your work. Director Craig, congratulations on your recognition. Sounds like that's very well deserved, and it's great that you were able to achieve that. So congratulations. My question, and if I understood the presentation and if my memory serves correctly, the legislature established the office long before they established funding to have a director. Is that correct?
The office was established without a line item to fund the office. It was established with the understanding, if I remember correctly, Senator Alvarado was one of the sponsors of that legislation, and there was not a line item to establish the office. What the Department for Aging and Independent Living did before Jennifer came on was we went after some grants to ensure that the office would be functional and operational to the best to serve individuals of the Commonwealth. To that, still today, we are grateful to the legislature for House Bill 6 for the restricted spending increase. However, there was not a line item to support the office, so the office continues to operate solely on federal grants.
But may I ask a follow-up?
Yes, go ahead.
Thank you for that information. This is so important to so many Kentuckians, and it's great that you were able to get the federal dollars in. Since this is a budget review subcommittee, right. I'm curious if more is needed from us in order to sustain the really life-saving and important work that you're doing.
To that, the department will never say no to money. Obviously, we understand and are very grateful for Jennifer's leadership in the 2.5 years that the office has been established in bringing in over $3 million in federal grants. To that, they are time-limited grants, and the office is only able to operate based on the grants. The department would be more than happy to have further discussion with you all as far as what a specific budget line item would be for the department's current operation, as well as expanded operations into the future over the next decade.
One follow-up comment?
Yes, you may.
Thank you. I just thank you again for that information. This is so urgently important for Kentuckians just trying to live their day-to-day lives. And I would hope that this committee would take very seriously our responsibility to make sure that this is funded in an ongoing and sustainable way, and that you're not having to constantly be searching for your next, ticket to stay afloat. So I'm very supportive of your office, grateful for the work you're doing, and I hope that we can provide more sustenance and assistance for you guys.
Thank you, Representative Wilner. Thank you.
Thank you, Representative Wilner. Representative Stalker?
Thank you, Chairman. 2 questions for you, ladies, and thank you for your presentation and the work that you're doing. It is vital. The first question is, first of all, an apology. This was prior to my time in office, but it's never helpful when we, this body, put forth some policy but not the funds to support the work. So I apologize for that, and hopefully we can correct that, and I appreciate have gone after federal dollars. My question is one, how much money would you need from us, the state of Kentucky? And the second question is, are there federal dollars that you have not been able to go after because of maybe matching restrictions, right? Because we don't give you anything,
Right.
and that might be a criteria for some federal funding.
Right. In the governor's proposed budget, what we had asked for was $410,000 to support the current operations of the office in addition to additional staff growth. That $410,000 is only for staff in and of itself. I believe, if my recollection recalls, House Bill 6 included in $360,000 in restricted revenue increase. So again, to that, not a direct line for funding. The money requested was only for staff, not for additional programming or any other pieces to that. So, at minimum, $410,000 to sustain Jennifer's position in addition to the additional staff to operate. Beyond that, it is one of the visions of that Jennifer had shared is to have dementia care specialists funded in each of the area development districts to truly support individuals and coincide with the work that is going on in supporting individuals in their communities. And so we can have some additional discussions on that, but at a minimum, $410,000.
Okay. A follow-up question, please.
You may.
Thank you. What do those numbers look like? So I feel like I'm asking for two different sets of numbers. One was, so we want to sustain Jennifer's position, absolutely. How many additional people would we be adding to that team? And then the other question is, as you just talked about, we'd like to have other individuals in, and I don't know if I'm going to catch the phrase right, but in other districts or areas. How many individuals would that be?
So the first question, as far as staffing, the $410,000 was to secure her position, and then Jennifer, if I'm correct, 2 additional positions. So a coordinator position, and then 2 social service specialists. So that is, again, just for the ongoing staffing. For the additional positions out in the field to support family members, that is a number that we would have to come back and provide with you, and more than happy to do that, Representative Stalker.
Thank you all so much.
Thank you.
Well, once again, Madam Director and Madam Commissioner, I really appreciate the time that you've given us here today. And unless there are any other questions, you all are free to go.
Thank you.
Not those you on the committee here. Before we adjourn, I want everyone to know that our next scheduled meeting will be August 21st. It should be in this room. Am I correct? Am I correct? Okay. Now, the next item is adjournment. Do I hear a motion? Motion for an adjournment. We won't take a vote. I hear